The ability to examine the major joints of the body is a skill that can prove useful to all clinicians, but it's especially vital for the GP and of course us, the rheumatologists. 5 out of every 10 GP consultations relates to the bones and joints, and to be able to do a quick and efficient examination and have the right technique can lead to correct diagnosis and treatment. In this series of videos, we'll cover the skills of joint examination and introduce you to the economical ways to examine the joints of both the upper and lower limbs, taking just a few minutes each. We're also going to show you how to use basic history and examination technique to diagnose some of the more common causes of painful or swollen joints where injections may be given as treatment. The joints we will examine are the shoulder and the elbow of the upper limb and the region of the hip and the knee in the lower limbs. Within each video sequence, we will combine examination, basic history of the common joint problems and how best to inject them. Whilst the exact techniques for joint and soft tissue injection may vary quite widely between different people giving injections and still be effective, there are some basic principles to adhere to, together with guidance as to the equipment that you may want within your clinical area that will make life easier when giving injections. You may want to make a note of the basic equipment you might need. I'm now going to show you the various pieces of equipment you'd have in your injection trolley or tray. To start with, a range of different syringe sizes going from 2 ml for local anaesthetic through 5 and 10 ml for injection, small joints and large joints, and 20 ml syringes for aspiration, and quite often with a large knee effusion you'll get through several 20 ml syringes. You've then got the cleaning equipment. Some people use styrettes, but I have to say I've never found necessarily that they will clean as big an area as I want, and I tend to use gauze with Unicept, the pink cleaning fluid, or normal saline to clean around a large area around the injection site. A marker pen, I tend to use Baro. Some people actually use the ends of their thumbnails to mark in a cross pattern, but I find Baro won't be washed off completely. And then a range of needles, 21 gauge green for aspiration, the larger bore, then 23 and 25, the 25 for doing small soft tissue injections and the 23 for doing most injections around the shoulder and elbow. You've then got ethyl chloride spray, which tends to be kept in either a fridge or a cool area, or otherwise it evaporates, really for using on the skin to give almost a sense of analgesia across the skin. You've then come to the nub of it, which are the things that you inject. You tend to use local anaesthetic, and I tend to pre-fill the syringes with a mixture of local anaesthetic and the steroid. You then basically have 2 types of steroid. You have the depot steroid, which is either depomedrone, or the slightly cheaper and probably just as effective depot triamcinolone, and those come in 80 milligram, 2 ml, or the green topped bottles, which are 40 milligram or 1 ml, and most joints tend to accept 80 milligrams or 2 mls with a mixture of 2%. What you've got to be quite careful about is when you're injecting into soft tissues, use hydrocortisone acetate, or the shorter acting hydrocortisone, really to try and minimize the risk of subcuticular fat necrosis which can occur with the depot preparations. So the basic rules are larger joints, depomedrone, smaller joints and soft tissue sites, hydrocortisone. Safe injection requires the skin area to be cleaned well first, and for the injection to be given within a no-touch field afterwards to minimize any risk of infection. Some people use gloves for injection, but I find that they're clumsy to use for most injections. It's difficult to estimate the incidence of infection after joint injection, but with reasonable cleaning, most estimates are around 1 in 5,000. I use a sterile gauze soaked with an antiseptic solution instead of an alcohol wipe to clean the skin area, but either will do. Before cleaning, I will mark the exact site of my proposed injection. I use a ballpoint pen or a felt pen marker, and enough is usually left after cleaning to guide the injection. When the area is to be injected and marked and cleaned, I then spray a few seconds with ethyl chloride. a cold, almost anaesthetic spray that results in a partial numbing and improves the patient's experience of injection. In some cases, I'll use a full local anaesthetic into the skin area around the injection, especially when people may be very anxious or I think the injection might be difficult. A supply of varying gauge needles, 21, 23 and 25, are useful, and syringes from 2 mils through 5, 10 and 20 mils that are used for large aspirations are helpful, as different combinations are suitable for different sites. The correct choice for drugs is important. Injectables include different types of steroids and 1 and 2% lignocaine without any adrenaline. Our basic principle is to use short-acting steroid for soft tissue and small joint sites where there may be some leakage of fluid into the surrounding tissues, and methylprednisolone or triamcinolone, which I don't use, for large joints. I always mix the steroid with some local anaesthetic within the same syringe before injection, and I find this gives a better short and medium-term result than steroid alone. Why use different steroids? Well, one complication of joint injection with steroid is the potential wasting of fat beneath the skin in the area of injection. This is known as subcuticular fat necrosis. This is seen more often with longer-term preparations of steroids such as methylprednisolone, which I use, or triamcinolone, especially if these preparations are used in soft tissue sites. Even though rare, this can be a major cause of patient complaint and can be very unsightly, as in this example, after an injection in the side of the ankle, probably for a plantar fascia. Taking consent before injections is variable, and I find that GPs tend to take formal written consent when injecting, and hospital doctors like me take verbal consent. There doesn't appear to be any legal obligation to take written consent as long as the procedure is explained. Potential complications such as pain during and after injection, infection risk and risk of subcuticular fat necrosis are explained, especially the latter. It's important to tell patients that they may get pain for up to 48 hours after the injection, especially if this is in the shoulder or elbow, in order to avoid unnecessary patient distress and unnecessary contact with you after the injections. However, if the pain is accompanied by a redness or swelling around the injection site, then obviously the patient should be encouraged to contact the injector, and a contact number should be given to them. If you're starting injecting for the first time, what I would suggest you do is to try and keep a reflective record of your practice. I think that's very useful for continued professional development purposes and keeping a record and an audit of your injections, but it's also good for reflection because a simple design like this one, Joint Injection Workbook, which I give out to people who come on the joint injection courses, allows you to put down the date, the site injected, the drug injected or the drug mixture, and the outcome, both in terms of how difficult the injection was and perhaps with a follow-up telephone call to the patient to see how they did. It allows you to keep the numbers that you've done at each site, and also to record when you feel you've achieved competence and a good outcome, and I think it can be very useful. In the next section of this program, I'll show you the specifics of joint and soft tissue injections at different anatomical sites. In this section, we'll be looking at how to correctly diagnose problems of the shoulder and elbow, using history, clinical examination, and then how best to inject them. The most basic principle of joint and soft tissue injection holds for this. Make a correct diagnosis and your injection stands a chance of working. Inject correctly into an incorrect location and it won't work at all. We'll look at the shoulder and the 4 main pathologies that can respond to injection, and then the elbow entheses, and the olecranon bursa. For a very effective, basic and short examination of the muscles and joints of the upper limbs, you can use the GALS technique: gait, arms, legs and spine. The Arthritis Research website has a video clip of how to do a GALS examination and also how to regionally examine other joints within the body. This can be accessed via their website without a passcode. And now for the shoulder. We'll look at the 4 commonest causes of primary shoulder joint pain. As with any other joint problem, preliminary diagnosis is made with a combination of history and examination. The commonest problem is probably shoulder capsulitis, followed by shoulder tendon trouble, with the more unusual problems of biceps tendinitis and acromioclavicular joint pain encountered less frequently. Each should be looked at in greater detail as we proceed. Each of these problems can be amenable to injection given accurately to the correct anatomical site. 11 per thousand per year incidence of shoulder pain seen in the community, and about 1% of adults consult their GP for shoulder pain each year. Self-reported shoulder pain occurs in approximately 25% of adults in the community every year. In a Dutch GP study, 29% of people with shoulder pain had rotator cuff pain, and the majority were treated by referral to physiotherapy, despite the fact that there's no evidence that physiotherapy has any role in treating shoulder pain from a large recent BMJ review a few years ago. Only 22% of those in the Dutch study received an injection in primary care on the first occasion. We'll now move to discuss shoulder capsulitis. The glenohumeral or shoulder joint is a ball and socket joint surrounded by tendons and ligaments that give it stability. The four basic shoulder tendons comprise the rotator cuff apparatus, the supraspinatus, most amenable to injection, the infraspinatus, the subscapularis and teres minor. The most common glenohumeral joint pathology is capsulitis. In this drawing, you can see the inflamed shoulder capsule and can imagine that when the shoulder's moved, in almost any range it'll hurt. Shoulder capsulitis is painful at rest and especially at night, and sleep can be very difficult. There are various causes of capsulitis. Previous dislocation or injury or trauma as a trigger. People who are diabetic get a greater incidence of capsulitis, and capsulitis and shoulder inflammation can clearly occur in other inflammatory joint diseases such as rheumatoid. Osteoarthritis and crystal-based inflammation can cause capsulitis, and sometimes you'll see a capsulitis spreading from one side to the innocent shoulder on the other side, probably due to neural connections. The clinical presentation suggests that capsulitis occurs when there's pain on capsular movement. Swelling in the shoulder is hard to detect, but restriction of movement is common, and there becomes a progressive loss of the range of movement as the shoulder moves towards a frozen shoulder. This can start as an acute, relatively minor injury and can gradually lead to loss of movement, which we call an adhesive capsulitis. And then there's progressive restriction, an adhesion of the muscles of the rotator cuff. And finally, a full frozen shoulder is a shoulder that really won't move at all. And by the stage that develops, the natural history of recovery will take another 12 to 18 months to full recovery, and almost no intervention will help. For the best results, shoulder capsulitis should be treated by injection as early in the course of disease as possible. With the development of adhesions, the loss of shoulder movement, the chance of pain after injection increases and the benefit decreases. Whilst the studies show no role for shoulder injection for a complete frozen shoulder, I personally find that injections can still be helpful, although you have to give several injections sequentially to provide benefit. We'll now move on to supraspinatus tendinitis. This is the second commonest cause of shoulder pain and can be associated with injury or inflammation of the supraspinatus tendon. In common with the other tendons and muscles of the rotator cuff, the supraspinatus can also undergo chronic degenerative change and spontaneous tearing with age or injury. In these cases, injections probably have no role, and a shoulder surgeon should be consulted. Imaging with ultrasound or MRI may identify these cases better. The supraspinatus muscle and tendon abducts the shoulder beyond the first 20 degrees of movement. The supraspinatus takes its origin from the greater trochanter of the humerus and inserts into the supraspinatus fossa of the shoulder blade or scapula. Inflammation of the supraspinatus tendon can be called one of several names according to taste, and this often causes confusion. It can be known as subacromial bursitis, painful arc, or impingement syndrome. As movement through an arc of abduction reproduces pain, this becomes known as painful arc. In orthopedics, it tends to be called impingement, because as the humerus abducts, it gets pulled up towards the acromion and traps the inflamed tendon momentarily between the head of humerus and underside of the acromion, causing pain or impingement. As the tendon runs across the shoulder, it can create a virtual bursa, the subacromial bursa, which can also be used to denote tendon pathology. A bursa, the subacromial bursa, separates the superior surface of the supraspinatus tendon from the coracoacromial ligament, the acromion, the coracoid and the deltoid muscle. It's often a virtual space. This drawing, representing the shoulder, demonstrates that calcification can sometimes cause irritation of the supraspinatus tendon as it runs within the notional subacromial bursa. Ectopic calcific deposits occur more commonly in diabetics, after trauma, and in those with chondrocalcinosis or pseudo-gout. These deposits contribute to irritant inflammation, and a plain shoulder X-ray can be used to demonstrate the calcium deposit. This condition can occur as an extremely acute presentation or more gradually following minor injury or overuse. Supraspinatus tendinitis is painful through an arc of movement and is especially prominent when the patient is asked to lower the shoulder from an elevated position. An almost audible catch and exclamation of pain often results as the shoulder is lowered. Movement tends to be free and painless in rotation and above the painful arc of movement. Whilst shoulder injection, if done smoothly and correctly, can be relatively painless, it can be complicated by pain for 24 or 48 hours after injection, and the patient should be warned of this before any injection is undertaken. And now for the biceps and acromioclavicular joint inflammation. Biceps bursitis, inflammation of the tendon of the biceps as it runs up the inside of the upper arm, can be diagnosed by palpation in the biceps groove of the humerus. It's often a result of overuse. Swelling's rare, and biceps rupture with a degenerative biceps can be common. If biceps tendinitis has been chronic and rupture occurs, this can result in an acutely painful bruise and the development of a Popeye-like muscle that stands out over the biceps. This change can be very worrying for people, but relatively innocent, and movement of the arm can be restored, albeit with a little biceps weakness, without the need for surgery. The pathology of the acromioclavicular joint is a little more unusual and often follows injury, either a direct blow onto the shoulder or a distraction injury of the arm being pulled. There can be local tenderness and swelling over the acromioclavicular joint, and X-rays can demonstrate change of osteoarthritis, and you can get the feeling of impingement below the acromioclavicular joint when the supraspinatus tendon is moved. I'm now going to introduce you to the shoulder. We'll have a quick look around the anatomical points, some of the movements that determine the difference between a capsulitis and a supraspinatus tendinitis, and then I'm going to show you injection of the glenohumeral joint, the capsulitis, and injection of the supraspinatus, the subacromial bursa, and then quickly show you how to inject a biceps tendinitis. So firstly, we've got nice, easy to examine shoulder with a collarbone coming up through here to the acromioclavicular joint. His acromion is well shown there, as he's not got a lot of fat over the shoulder, and you can feel underneath the acromion it goes all the way around to there. The biceps comes down there, and the biceps tendinitis occurs there. So the injection points are really going to be determined by what the diagnosis is. What I'm going to do is show you the difference between the demonstration of a capsulitis and the demonstration of a supraspinatus tendinitis. So a capsulitis is really demonstrated by moving the joint through the full range of capsular movement, so across, touching the low back, coming up there to touch the base of the neck, and If there's a capsulitis, it's likely that some of these movements would be restricted, and in fact trying to move them further through the range of movement would be painful. So restriction across there is a capsulitis. A supraspinatus tendinitis will give problems in the arc of movement, the supraspinatus cutting in after about the first 20 degrees and moving up to around about 120 degrees. So the best way of demonstrating that is to ask the patient to hold their hand up where the extreme of capsular movement it'll be pain-free, and then asking them to slowly lower the arm, and around there you'll often find that there's a clunk, a feeling of almost something giving way and pain, and then it moves through the range of movement, and that's what's known as a painful arc. The biceps is altogether easier, and biceps tendinitis causes pain just below the shoulder when the patient's moving the biceps, and the way to demonstrate that is to go into the bicipital groove of the humerus and just feel down there. It's quite an uncomfortable palpation anyway, but do it lightly, and somewhere around there you'll come across quite a marked feeling of tenderness, and that's where the tendinitis is. So we'll now inject all three of those areas. I'm now going to show you how to inject the glenohumeral joint, or for a capsulitis. Some people will inject anteriorly, just alongside the coracoid process, but I've never found that particularly happy area to inject because we're confronting the patient. I'd far rather be standing by the side of the patient and injecting in along just behind midline. So the way you work the landmarks out, and I'm just going to draw a mark on Sergei's arm, which he's happily agreed to let me do. And if I identify for you the margin of the acromion, underneath that is the head of the humerus, and the capsule of the joint is all around it. And what I tend to then do is to take a point in the midline and go just a couple of centimetres back from that, and that's going to be the access point to the shoulder. And the needle will come into that area and point towards the left-hand nipple, so slightly down and across. So if I mark the point of access just there, we'll then prepare that area and inject. So using some Unicept or saline solution, we'll clean up the area around there, and you'll see that the Barrow marks are still quite well visible on that. And then use some ethyl chloride spray to anaesthetize the area. And then, because it's a large joint, we can use a depot methylprednisolone, depomedrone, and I'll use 80 milligrams of depomedrone, and probably anything up to another 6 or 7 mils of 2% lignocaine in the same syringe with a blue needle. And I'm just going to inject you now. The needle just slips under the acromion and then goes down towards the area, and you can see it just slips in very easily right to the hub, and then there should be a very easy flow of fluid into the shoulder. If it's not easy, then you may not be in the right place. So that's to inject into the glenohumeral joint. This next injection is an injection into the subacromial bursa, so the bursa that sits underneath the acromion. And in fact, to the non-educated eye, it looks an almost identical injection to the glenohumeral injection, but it actually goes into a different area. So once again, mark out the area of the acromion, which in fact when you've done several injections you won't have to, but it's useful when you haven't. Sometimes it's quite difficult to identify the acromion in well-covered people. And then this injection is exactly in the midline, so it's actually in the line of the midline. Instead of going down and across, it goes up and under, as they say. So what I'll do is clean that area, and we're going to be putting the needle in just on the cross of those two lines. We'll use some ethyl chloride spray, try and protect it from going all over his face, and then on this occasion, because we're injecting into a soft tissue site, we use hydrocortisone acetate to minimize any tissue damage that the injection may cause. And you put the mixture in with local anesthetic. The needle slips just under the acromion and then can turn all the way through to there, and then goes right the way up to its hub, and it's now sitting right in the subacromial bursa, and I can then inject the fluid up into the bursa, usually to very good effect. There's two more injections that you will sometimes need to do in the shoulder. One that's quite unusual, which is an injection into the acromioclavicular joint, which using a little orange needle. And on this occasion I will always anaesthetize the skin, because sometimes it's quite difficult to get into the acromioclavicular joint. And just using this pen as an example, it's an injection directly into there, and the joint is a very small joint there and takes only 1 ml or so of fluid. And the one perhaps that's slightly more common is the biceps tendon or biceps tendinitis injection, which you identify the landmarks really going down the biceps groove of the upper arm, just if you can see it just there with my finger. And there'll be an area of tenderness within that groove, and go about a needle length below that and mark a point there, and the injection is going to come up and into the biceps groove. So same procedure as the other injections, and again on this occasion it's going to be hydrocortisone acetate and local anaesthetic, so the short acting. So clean around there. It's a slightly more difficult injection for the patient because you're confronting the patient with it. Spray the area of needle entry with ethyl chloride, and then using the mixture again of hydrocortisone acetate and local anaesthetic, slip the needle deep down to the biceps groove and then up along the biceps groove right to the hub of the needle, so that it's actually sitting, the needle sitting around there, and then inject in and around the area of the biceps tendon. There are a number of ways of practicing joint injection. Firstly, you can look on the internet, and YouTube now have a series of demonstrations of joint injection. Also, there are a number of manuals, and the only difficulty with the manuals is that they'll all show you a slightly different technique and slightly different anatomical landmarks for injection. But I've found this book, Joint and Soft Tissue Injection, to be reasonably helpful, and whilst I don't fully agree with some of the landmarks, they're actually done quite clearly with photographs and anatomical cartoons, and I think it's for the practice and just revision, it's quite useful. There are also joint injection models, and whilst very expensive, and if you do happen to own a set as I do, you have to guard them with your life, because grubby practicing hands will mark the skin, so get people to wash their hands and wear gloves before practicing on it. But what you can then do is you can identify the different areas for injection, so the capsule injection, the subacromial injection, the acromioclavicular, and if you're in the right place, one of the green lights goes on, and they come with a manual of suggested injection techniques. So in a rather compromising way, I'm now going to show you how that works. So not only am I going to inject left-handed, being right-handed, but I'm also probably going to get it in the wrong place. So I will try and inject the subacromial area there, and if I'm anywhere near it, oh look, the glenohumeral light's gone on, so the subacromial or glenohumeral light will go on. So practice away. Now we'll move on to the elbow. Patients often complain of elbow pain, and the elbow can become swollen and need either aspiration or injection or both. It can be involved in inflammatory arthritis such as rheumatoid, and is more commonly involved in a crystal arthropathy, especially gout in men. Injection can be fiddly, but it's worth mastering, as it can be a very useful part of your injection armament. Next, we'll consider the elbow entheses. Inflammation of the entheses, or whether tendons insert into bone at the elbow, are common, and they're known colloquially either as tennis elbow, if the lateral enthesis is involved as here, or golfer's elbow at the median side, even though neither sport is necessary to develop the problem. The average tennis elbow sufferer who plays tennis is a 45-year-old who's been playing tennis for 16 years, has played 8 hours a week before the onset of pain. So clearly there's a lot of tennis involved in tennis elbow. As the lateral epicondyle is where the extensors of the forearm find their insertions, then forced extension of the elbow against resistance will reproduce the pain, as can local palpation over the lateral enthesis. Injection's relatively straightforward and will be demonstrated next. The elbow joint itself, a slightly tricky joint to inject, but a very useful one. As you can see, elbow inflammation and effusion in patients with rheumatoid arthritis and crystal arthropathy such as gout. And then I'm going to show you two injections which are really quite commonly encountered in general practice: the lateral epicondyle, or tennis elbow, and the medial epicondyle, or golfer's elbow. There are a number of ways of aspirating and injecting the elbow, but the one I'm going to show you is the one that I normally find easiest for me. First, identify the tip of the olecranon, then move your finger out about 2 centimeters and up about 2 centimeters. You'll then find that there's an area just above the elbow, still within the confines of the elbow joint, where a needle will quite easily be slipped with minimum of discomfort. So when you've got that identified, mark across that area and then prepare the site for injection with either saline or Unicept solution. Perfectly all right to have the elbow resting on a couch. And then, to make it more comfortable for the patient, I'm just going to spray some cold spray on you. Use some ethyl chloride spray just around the area, and as you can see, the couch as well. Then, having sprayed it, I'm going to take a 23 gauge blue needle and an empty 10 ml syringe and pop it in. You just actually don't aim straight in, but aim just slightly across and in, and the needle slips quite nicely into the joint itself and allows you then, if there's an effusion, to start aspirating. A little bit of fluid there. Once you've aspirated, you can use your hands to just disconnect the syringe from the hub of the needle and put in the solution to inject without having to do 2 separate injections, and then you'd inject it straight into the elbow. I'm now going to show you the lateral epicondyle injection, just to demonstrate the tenderness over the lateral epicondyle. It's going to be anywhere around this area, either just behind the epicondyle or, in Sergei's case, over the... Do you feel that hurting? Mm-hmm. Just over the area of the epicondyle. And we can just check that it's tennis elbow by asking the patient just to lift his hand up like that and push downwards, resist against it, and you can see all of the muscles of the forearm. He's got very well developed forearm extensor muscles. And by doing that, does that hurt when I do that? Yeah, you can find a tenderness in there. So we've established that the area of maximum tenderness is there, and using the same pen marking technique as I use in other areas, put a mark around there. Sometimes I'll just put an area of injection around, and using the same technique for cleaning, clean around with Unicept or saline around the area. Use the ethyl chloride spray, just the cold spray coming. Just around there, and then take the prepared solution of hydrocortisone and local anesthetic, and it's just a direct confronting injection that goes absolutely at right angles and goes down and onto, you can just feel now the periosteum, and I can then now start to inject around the area and raise a bleb of fluid around the elbow. The medial epicondyle, or medial epicondylitis, or golfer's elbow, is often a problem, not in golfers at all, but in people who've used the flexors of their forearm. If you actually get the patient to make a straight hand and then push upwards against me, you can see all the flexors of the forearm tense, and they all come down and take their attachment from the medial epicondyle, which is just around there. So that will reproduce discomfort just by forced flexion, and I can then find out exactly where the tenderness is. And it's a slightly awkward position because I'm having to rotate the arm round, and just around there will be the point of maximum tenderness, just and sometimes just around the edge there. So exactly there, and that's where I'm going to mark up the area for injection. Just around there. I've now marked up, and I'm going to just ask him to bring the arm around this. I'm taking a slightly awkward angle for me because usually I'd be coming in from this area, but I really want to show you the landmarks. So I'll clean up around the area. I will then use the ethyl chloride spray on the area, and then I'm going to use either a blue or an orange needle with hydrocortisone acetate and local anaesthetic, and I'm going to come in confrontation towards the medial epicondyle injection. Just going to come in now and take it down to the area of the periosteum, and then start to just inject all the way around there. I'd usually be at a more comfortable angle, but this will be very effective. As a principle, the greater the injected volume, the better the result in enthesis injection. Injections even been tried with plain water or saline to show benefit, showing that at least part of the therapy is using fluid to forcibly separate the inflamed tendon fibres at their insertion to allow healing. Make sure that for these injections, as for all soft tissue injections, that you use hydrocortisone rather than a depot steroid to minimise the risk of unsightly subcuticular fat necrosis reaction. If you can then teach the patient exercises to hyperextend the elbow, then healing will be enhanced. Golfer's elbow or medial epicondylitis is a similar overuse injury and can be injected in a similar manner over the medial epicondyle. In this instance, injury is due to overuse of the flexors of the forearm, and flexion against resistance can reproduce pain. You can get it after carrying particular heavy bags, or in our part of the world, Surrey, you can get it after playing golf. Inflammatory olecranon bursitis over the tip of the elbow can be both unsightly and painful. After trauma or with crystal arthropathy such as gout or bursal infection, fluid can accumulate as a discrete, almost egg-like swelling, which can grow large in size over the tip of the elbow. Normally, if the bursa looks inflamed, fluid is first aspirated before any injection is given to eliminate the possibility of bursa infection. If this is at all likely, then antibiotics should be given to cover staphylococcal or streptococcal infection possibilities. Injection technique is easy, and the bursa can accommodate a mixture of short-acting hydrocortisone and local anaesthetic to good effect, and can usually be done with ethyl chloride spray rather than local anaesthetic. Occasionally, the bursa fluid reaccumulates so quickly that surgical resection is necessary, although healing after surgery in this location can be tricky, and you're often left with a leaking sinus for several weeks. In this section, we'll look at the regional anatomy of the lower limb, with focus on the hip, the sacroiliac joint, and the soft tissues around the hip that are often responsible for hip pain, and then the knee. We'll look at how we can make accurate diagnoses of lower limb pain, and how joint and soft tissue injections can bring about timely and effective pain relief and cure. The hip joint is a pelvic joint, and the three pelvic bones all contribute to the anatomy of the acetabulum, or the cup of the hip, as shown here. The hip is a straightforward ball and cup joint, but the area around the hip is a complex of muscle and ligament attachments, giving the joint stability and movement. In clinical practice, the GP will often encounter sacroiliac joint pain, making the diagnosis by finding tenderness on direct palpation of this linear joint. Sometimes this occurs as part of a wider seronegative arthritis, and sometimes after a twisting trauma or back strain after picking up heavy objects. Sacroiliac joint pain can be disabling and can occur on any movement, and especially at night. Injection can be very helpful, but as this joint sits deep to the muscles of the lower back and buttock, any injection needs to be done with X-ray or ultrasound guidance, as shown in this graphic illustration. Hip joint pain can be misleading to both the GP and the patient. The hip joint actually sits within the outer third of the groin and in the inguinal region, and localized hip pain can be felt there or can be felt as referred pain to the knee. Examination of the hip joint can be helpful in deciding whether the hip is involved or whether the pain is actually arising from the bursae around the hip. An X-ray of the hip is easy to obtain and often distinguishes between hip pain and pain from around the hip arising elsewhere. Causes of localized hip pain include osteoarthritis, and the hip can be involved in inflammatory arthritis. Interestingly enough, never in rheumatoid arthritis, but more often in seronegative arthritis, such as you see with ankylosing spondylitis or psoriasis. Hip joint injection is almost impossible without X-ray or ultrasound guidance and is therefore done as a booked procedure, often in radiology departments. The joint space is large and large volumes of fluid need to be injected by the radiologist. The anatomy of the hip is complex. The approach to the hip, as seen here, is often from the lateral side. In many patients, hip pain actually represents pain in the bursal tissues around the hip. The three main bursae are the trochanteric, the gluteal and the ischial bursae. We can see the anatomical regions of the three bursae here. The blue areas in this diagram denote the areas of inflamed bursae from where the pain arises. Bursae are areas of tissue between the muscles and tendons as they slide across the bone and act as lubrication. The bursae rest at points where muscles and tendons slide across the bone, and the healthy bursae create a smooth functional gliding surface, making normal movement painless, and therefore when they're inflamed, any movement becomes uncomfortable, especially lying in bed at night on the side of the bursa. There are a variety of causes of bursitis, including repetitive trauma, excessive pressure over the outside of the hip or the area of the back, inflammatory disease such as rheumatoid arthritis, and more uncommonly, infection. Often the bursae arise as a result of asymmetrical movement, such as when people are walking on crutches or after an injury elsewhere in the lower limb. Examine the hip joint to ensure that there's no irritation or restriction. Examine the sacroiliac joint to ensure no tenderness, and then directly palpate over each bursal area. Then palpate down the outside of the thigh, down the lateral fascia or the iliotibial band. And when there's a bursa with hip pain, this can be extremely tender. The iliotibial band, also known as the lateral fascia, runs down the outside of the thigh. It inserts inferiorly to Gerdy's tubercle on the lateral tibial condyle and superiorly to the iliac crest. The gristle-like band is shown here extending from the upper outer thigh down to below the knee. I'll now show you the examination technique and injection for the trochanteric and the gluteal and ischial bursa. I'm now going to demonstrate examination and injection of the different bursae that you find around the hip. I'm going to show you about the trochanteric bursa and the lateral fascia, the gluteal bursa, and we're just going to briefly mention but not inject the ischial bursa. I'll start with perhaps the most commonly encountered bursa, the trochanteric bursa, and the associated tissue, the lateral fascia. The trochanteric bursa is usually found in the area just above the greater trochanter of the hip. In someone who's thin like this without too much covering, it's quite easy to see where the greater trochanter is, and it's just there. The lateral fascia, which is running all the way down the outside of the thigh, is often involved and is extremely tender if you press down it when somebody has a trochanteric bursa, even to the point where people don't know it's going to be tender when you press it. Around here, if you press directly on the trochanteric bursa, it allows you to identify exactly where to inject. So the point of maximum tenderness, if you'd like to just tell me where it's most tender, is that Is that where you're finding it most tender?
Yeah.
And that would be where we would put the injection in, and we do it with a blue 23 gauge needle. Looking at the gluteal bursa, there's a much wider area where the gluteal bursa might be, and it's where the gluteal muscles overlap on each other. And the bursa is a virtual space, but sometimes can even be demonstrated using an MRI scan or ultrasound. And the same principle applies, feeling around the bursal area until you get the point of maximum tenderness, which on Sergey, let's anticipate would be just around here, and you can almost roll the gluteal muscles underneath. So the injection for the gluteal bursa, which I'll show you, would be in this region of maximum tenderness. The slightly more awkward bursa, and thus the rarer bursa to look at, is the ischial bursa. And usually people complain about the ischial bursa when they're sitting down because it hurts. And if you just, in the rather delicate area just underneath the buttock, push down on the ischium just underneath there. I can feel it underneath my fingers. And somebody who has an ischial bursitis would go, ouch, at this point. And you can imagine an injection around here is just a little more difficult and delicate to do. I'm now going to show you how to inject. Once again, having washed my hands, I would take a marker pen to mark over the area that we've predetermined as the most painful area above the trochanteric bursa, and mark it with a pen mark. I then clean with my Unicept or saline solution around an area all the way around that injection site. And then to make it a little bit more comfortable for Sergey, I'm going to use some ethyl chloride spray, just a cold spray coming now. And you can see that almost freezes the area. It then allows me to approach with a blue needle, a 10 ml syringe filled to 6 or 7 mils with a mixture of, on this occasion, hydrocortisone acetate, a short-acting steroid, so we don't get subcuticular fat necrosis, together with local anesthetic. And we're just going to inject now around the area we've sprayed on. Just put the needle on the bursa and take it down so that it goes deep down, and then you can inject whilst just moving the needle around slightly, so you can then completely empty the syringe, which I'm not going to now, but you've got a good injection in the area of the trochanteric bursa. I'm now going to move on and inject the gluteal bursa, and once again the predetermined area of maximum tenderness is there, so we're going to put a mark across there, just behind the back of the trochanter, and after cleaning the area with saline or Unicept, we'll do our spray of ethyl chloride into the area, just a cold spray coming. And now I'm going to inject. You'll just feel a needle coming in, again a blue needle, and just support the needle and put it into the area, deep down to the hub of the needle, and that'll take you down to the area of the gluteal bursa, and then you can inject in and around the area of the bursa to good effect. And it's unusual for you not to have a nice response to this sort of injection. The trochanteric bursa is perhaps the most common site for tenderness and pain involving the bursae. It most frequently occurs in postmenopausal women and causes pain on standing from a sitting position for a while, makes it hard to lie on that side at night, and when severe results in limping and difficulty going up and down stairs. Several bursae exist between the gluteal muscles and the blade of the ilium, and between the 3 gluteal muscles. The function of these is to reduce friction between muscle layers during vigorous activity of the lower leg. As with all bursae, inject locally over the point of maximum tenderness. Injection of the ischial bursa is a little more tricky due to its location. The position of the ischial tuberosity is shown here. An injection usually involves lying patients on their side to achieve an accessible position to the area just underneath the inside of the buttock. In this section, we'll look at examination and injection of the knee joint itself, as well as some of the surrounding structures that can become inflamed and respond to injection. These other structures include the anserine bursa and the patella and patella support tissues. The knee is a shallow hinge joint that relies on strong ligaments and the muscles of the thigh and hamstring for its stability. The cruciate ligaments that are shown here, with the patella reflected off the knee, also give the knee stability. The collateral ligaments down the sides of the medial and lateral knee are all vital to knee joint function and strength. Knee pain in the community is common and presents a problem of diagnosis and treatment for the GP. Knee pathology, whilst varied in diagnosis, can be classed broadly as inflammatory, mechanical and degenerative. Whilst all may respond to injection, inflamed knees respond best as the injection with steroids are acting as an anti-inflammatory within the knee. In the rheumatology clinic, I encounter inflammation in the knee associated with inflammatory arthritis such as rheumatoid or reactive arthritis. Equally often, or even more frequently, knee joint effusion and inflammation is associated with crystals such as gout or pseudo-gout, crystals of calcium pyrophosphate, and crystals from a more degenerative origin associated with osteoarthritis. These are crystals of hydroxyapatite. When knees are very worn and little cartilage is left, joint injection can still provide considerable anti-inflammatory relief. Let's now see how to examine the knee. Hello, Sergey. If it's all right with you, I'm going to examine your knee and then we're going to do an injection into the right knee, the one that hurts. Is that okay? I'm now going to show you how to demonstrate an effusion on the knee. In fact, Sergey doesn't have an effusion, but there are two fairly simple procedures that you need to be familiar with. Sergey's knee is lying flat on the couch, and I'm going to show you the first technique, which is to take the fluid out with my thumb from the medial pouch where it gathers up into the suprapatellar pouch. And when there's an effusion, if I bring my whole hand back like that, you'll see a little lump appear there as the fluid moves down from the suprapatellar pouch. The second technique, almost everyone's familiar with, is called the patella tap. It's where you empty the suprapatellar pouch so that the fluid comes down into the knee. And when there's a lot of fluid, the kneecap is almost soft when you push on it and goes down through the fluid and taps down onto the bone beneath. You'll need to be confident in your ability to demonstrate a joint infusion, and this takes some practice. On the left, you can see swelling of the knee that can indicate joint fluid from inflammation. However, careful full examination of the knee is still important, and a guide to this is given by the Arthritis Research website video examination. When the knee is inflamed, the swelling may also be detectable behind the knee, sometimes known as a discrete hard swelling or Baker's cyst. Usually this isn't a true cyst, but represents synovial hypertrophy, which is connected to the true knee joint. Some people inject directly into Baker's cysts, but I've never found this adds significantly to knee joint injection and can be very uncomfortable for the patient, as injection in the back of the knee seems to be exquisitely sensitive. Knee joint injection itself can take place from either the medial or lateral side. I prefer the medial approach because the shape of the patella means that there's a less acute slope on the medial side and the needle can be slipped more easily beneath the patella to access the joint itself. I'll now demonstrate knee joint injection. I'm now going to inject Sergey's knee. First of all, I'm going to orientate the landmarks. The patella starts there and finishes there, and the best injection site is midway down the patella, and you can just see when I move there that his patella moves. Some people mark with their thumbnail, but I tend to mark with a baro or a marker pen. So when I've established the landmark, I put a mark across there so that then I can use this field as a no-touch field. What I tend to do is instead of to clean with a stirette, I'll use some gauze and also some Unicept or saline to clean up with. So I've put some of that on the gauze and I will clean up quite well round the area of the injection. I of course have cleaned my hands beforehand. I'll then in order to give Sergei the benefit of a little bit of local anaesthesia, use some ethyl chloride spray. I'm just going to spray something cold on the knee. Spray for about 10 or 15 seconds, and it really is quite a cold sensation. I've now prepared the injection site for injection. I have a 10 ml syringe that I've put methylprednisolone depot into the syringe, 80 milligrams, and some 2% lignocaine, 5 mils, mixed in the same syringe. And what I'm going to do now is to use a 23 gauge blue needle to inject, as there's no fluid to aspirate. If I was aspirating, I would use a 10 or 20 mil syringe with a green 21 gauge needle. Okay, I'm just going to actually do the injection now. So keep the field no touch, pop the needle just underneath, and just give it a little bit of an angle to start with to put the needle in, and then slip the needle round, and it goes nicely into the knee, and then allows me to carry on and put the fluid into Sergei's knee. It's worth emphasizing a few basic points from that injection session. Ensure the patient's knee is comfortable, and this can involve a support pillow beneath the knee, especially where the patient's holding the knee in slight flexion. Get used to using both hands, one on the syringe and one on the knee, to better empty the suprapatellar pouch where most fluid accumulates. This will help you to aspirate to dryness, and the outcome will be better when you inject the knee with steroid and local anaesthetic than if you leave residual fluid within the knee. It's worth knowing about the anserine bursa, as this can be the cause of knee pain and will not respond to knee joint injection and needs a local approach to the bursa. The anserine bursa comprises the insertions of the gracilis semitendinosus and semimembranosus coming together and looking a little like the webbed foot of a goose, hence the name pes anserinus. Diagnosis is by local palpation resulting in extreme tenderness. Injection with hydrocortisone acetate and local anaesthetic into the area of greatest tenderness can produce good results, but the injection can be quite uncomfortable for the patient, so try using lots of ethyl chloride spray. When the patient complains of pain below the knee and the tibial tubercle is tender and perhaps more prominent than usual, the diagnosis may be Osgood-Schlatter's disease. This is an enthesopathy or joining inflammation where the patellar tendon inserts into the tibial tuberosity and often occurs in adolescence or after intense running or training. When the tendon becomes inflamed at the top, at the margin of insertion into the patella, it's known as the Sinding-Larsen syndrome. Both can be extremely difficult to treat but may respond to injection with hydrocortisone and local anaesthetic locally to the areas of greater tenderness. Prepatellar bursitis, the term housemaid's knee, is still used, but in my experience it's more often encountered with carpet fitters and those whose work involves kneeling than it is with housemaids, can be easily recognised and does well with aspiration and injection, as long as you establish that the bursa isn't infected first. Aspiration's easy after using ethyl chloride spray, and you don't need to use local anaesthetic. Finally, inflammation of a patellar tendon does respond sometimes to injection around the inflamed tendon, but you must be careful to avoid injection into the substance of the tendon itself. It's worth mentioning the condition known as shin splints, pain beneath the knee, over the outer or tibial compartment of the leg, as shown in this illustration. This can be very uncomfortable when walking or at night and can be confused with pain arising from the knee itself. Tibial compartment syndrome can become very severe and is then recognised at this late stage by the 5 Ps: pain, pallor, paresthesia, pulselessness and paralysis if not treated. By this time, urgent surgical compartment release needs to be performed with the help of your colleagues in orthopaedics. I hope this introduction to anatomy and injection technique of the hip and knee have been helpful to you. There's no substitute for practice. Practice and more practice. The essential truth that injection technique is not complicated, but an accurate initial diagnosis is vital, holds for all these injections. Even if the injection's well performed, it will clearly not work if given for the wrong condition at the wrong site.